Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. It is my great pleasure to have Dr. Philip Otterbeck here. Dr. Otterbeck has many titles, almost would take up the entire show to talk about them. I know him from Staten Island. He's at Richmond University Medical Center with me. He's the chief medical officer at the hospital. He's chief of the division of endocrinology, and is also chairman of the Department of Medicine. So different ways of saying he's the head of a lot of different parts of the hospital. And he's really a tremendous advocate for patients, someone I know is a great friend, and someone who really has brought diabetes to the forefront on Staten Island. There's a lot of new things going on in diabetes. And when we think about diabetes, we think about medications for it, weight control, but what is diabetes and really how to get into it? And really, I know no one who could explain things on a more general level, for whether it's for physicians, whether it's for our wonderful audience, to understand diabetes. Because I think this has become something that you showed me some statistics before. About 97 million people, almost 100 million people have pre-diabetes, and we'll talk about what that is. Close to 40 million people have diabetes, and that's, I imagine, type 2. So we're going to talk about all that in this, and we're going to try to educate everyone as to what they could learn about it, because again, so many people, if you think about it, 140 million people out of 320 in the United States have some characteristics where they're being given the word diabetes. So thank you so much for coming.
It's my pleasure. Thank you for having me back.
Thank you. So let's talk about, to everyone out there, what kind of a doctor takes care of people with diabetes? And what training do you have to be able to take care of someone with diabetes?
So the vast majority of our patients with diabetes actually are taken care of by a primary care provider. And I say the word provider, not necessarily doctor, because many of our patients, both in New York as well as around the country, are being taken care of by what we used to call mid-level providers. Now they call them advanced practice providers, that is, nurse practitioners or physician assistants. So people that specialize in primary care, that is, doctors, physician assistants, as well as nurse practitioners, are the main folks on the forefront of treatment of diabetes, both type 1 and type 2.
So could you tell us the difference between type 1 and type 2 while you're saying that?
Absolutely. So type 1 diabetes is an autoimmune process. This is a typical classic case where we think about a patient in his or her youth, 5, 6 years old, that presents to the hospital just feeling lethargic, not themselves, and winds up to have very, very high blood sugar. And the presentation is many times called diabetic ketoacidosis, where there's a buildup of acid in the blood because of the high blood sugar. And this is a process by which those children will need to be treated with insulin for the rest of their lives to become insulin-dependent diabetics. Type 2 diabetes, in contrast, is, in our minds at least, is a disease where folks, as they get older, they gain some weight, and they go to the doctor, they get their blood sugar tested, and the blood sugar is elevated. This is due to both diet and lack of exercise modification. And these are the classic distinctions that we have in our head about what type 1 versus type 2 is. The problem with that distinction is that it's becoming blurred. As younger and younger people are getting heavier and heavier, they're developing what we used to think of as adult onset diabetes, right? And so those people are needing medications and diet and exercise modification much, much earlier in their lives. And similarly, the autoimmune process of type 1 diabetes, I mean, I think one of our friends and colleagues referred to me, I always say it's the oldest patient I diagnosed with type 1 diabetes and autoimmune process was actually in her 90s. So really there is some fuzziness in the overlap, but the classic understanding of type 1 being autoimmune and where the body attacks itself, the insulin cells, insulin-producing cells, and type 2 where people are becoming insulin resistant and need medications. Those things do hold, and there are exceptions and some overlap there.
We're going to speak most of our time about diabetes mellitus type 2.
Yes.
But let's talk about type 1 just for a second.
Yes.
As a neuroimmunologist, someone who does a lot of work with the immune system, there are a number of agents that I'm hearing that are being thought of that might help these youngsters or these younger adults when they're diagnosed with diabetes type 1. And again, when you said they're going to be lifelong going to be on insulin, and that's absolutely the treatment of choice. But tell us a little bit about some things that are happening to give some hope to that population. And clearly it's a much smaller population than the type 2 patients.
Certainly. People that have a family history of type 1 diabetes, as an example, there are certain blood tests that can be done in children and adults where there's some evidence of development of high blood sugar. And those tests are called antibodies. Those antibody tests, we call them GAD65 antibodies, the islet cell antibodies, insulin antibodies, and another one, zinc transporter 8 antibodies. And those, when they're measured in a patient that has not developed overt diabetes yet, but those antibodies are positive, that indicates a person, a child, with the propensity, the likelihood of developing type 1 diabetes over time. And what we have now are some new medications that are actually able to modulate or control that autoimmune process to slow it down and stop the destruction of those beta cells of the pancreas. Remember, the beta cells are the insulin-producing cells of the pancreas. So conceptually, if you could give a medication to slow down that autoimmune process, that in turn would delay the onset of that type 1 diabetes in those children. So it's an exciting field, and this immune modulation, as you referenced, that really has only come on the scene in the past year or two, and the ability to use it clinically. I mean, it certainly was available in research trials before, but now we can actually use that clinically. So a lot of my colleagues in pediatric endocrinology are doing those screening tests for those patients with family histories and actually treating those patients very, very early in the disease state to prevent the onset, which is exciting. And the longer you can prevent it, the better for those patients.
But this is not routine blood work or routine testing in most children.
It's not a routine test like, you would go to the doctor and the doctor would check your cholesterol level or your thyroid level or your kidney function. It's a select population of people that we know have the family history. That's why it's important to, when you see the doctor, not only to tell them how you're feeling, but tell them about the diseases in your family. And the doctor can think about that particular patient and say, is this somebody that I should screen for that propensity to develop type 1 diabetes? And if the answer is yes, it is actually as simple as a blood test, getting those screening tests, and then once the problem is identified, then referring the patient for treatment.
And maybe you could just mention or at least touch on the miracle of insulin. What happened to type 1 diabetics before insulin?
Well, type 1 diabetes was a deadly diagnosis, and essentially people were just basically given the best we could in palliative care. And they, had sometimes days to live, and sometimes they had months to live as their body did poorly. And sort of the miracle of insulin was it changed all that. And even I, although I've been practicing endocrinology since 2011, I have patients that are my patients that have been told me, the doctor told them as soon as they were diagnosed with type 1, although they weren't going to die because at the time they had insulin, they said, you will never do this, you will never do that, you will never have children. And I can't tell you, I saw 3 people today who are pregnant and have type 1 diabetes. So really, the miracle of insulin literally saved these people's lives. And not only that, but the technology that we now have, the continuous glucose monitoring, the insulin pumps that now integrate and talk to each other and tell the pump, okay, give a little more insulin, give a little less insulin depending on a patient's blood sugar. This has revolutionized the way we treat type 1 diabetes and really has allowed our patients with type 1 diabetes to live basically normal lives, with the exception of the fact that they do have to monitor their sugar and do have to give themselves insulin in accordance with their meals.
That's absolutely amazing. Yeah. So now we're going to go into diabetes type 2, which most of us think about as the routine diabetes, adult onset diabetes.
Yes.
How do you make the diagnosis? Is it just a blood test? Is it looking at the patient? Is it where do you go for this?
Yeah. So mostly diagnosis of diabetes is centered around blood testing. And there are 3 main ways that a provider would say, let's test this patient for diabetes. One would be a fasting blood sugar. So you fast overnight and have your blood sugar done in the morning. And if that number is 126 or above on 2 occasions, that would be consistent with diabetes. The other way is to do what's called a hemoglobin A1C, and that's a 3-month sugar number. Now that can be taken fasting or non-fasting. You don't need to fast for your hemoglobin A1C. And if that number is 6.5 or above, that would be consistent with diabetes. And lastly, and thirdly, a glucose tolerance test. Basically what happens is a patient goes to the laboratory fasting. They're given a defined amount of little soda, and they drink that soda. After 2 hours, if that number exceeds 200, that would be consistent with diabetes. So 3 main ways to do it, and all efficacious and all really tell us, this is a patient you really need to pay attention to.
Do you have to feel poorly to have a high sugar? So you think about it, people go for blood work, and they always ask, why do I have to go for blood work every year or about? And they say, I feel fine. So do people come to you, or at least are diagnosed with diabetes, feeling fine?
Yes, I think diabetes presents one of 2 ways. Diabetes present in someone that's following with their doctor and getting blood tests done pretty routinely. Diabetes is diagnosed really when a patient is feeling fine. There's no symptoms. That's the best way to diagnose it, because the patient hasn't had a chance to decompensate, and furthermore, you catch the disease as it emerges and then can treat the patient accordingly. In some patients that either haven't or don't follow up with a provider, they can have a dramatic presentation to the emergency department. In fact, they complain of excess thirst, weight loss, altered mental status. Right? These are the ways that people will present when they're not identified early in the disease. And of course, those patients many times will require not only an emergency department stay, but even admission to the hospital for stabilization of their blood sugar, until it's improved and they can be discharged safely on oral medication.
So when someone's told that they have diabetes, there are various diagnoses that scare people. And diabetes is one. High blood pressure, again, concerns of having a stroke or heart attack. In my field, telling people they've had a stroke or things like multiple sclerosis, there's a tremendous fear. What do you see amongst patients who you tell that they have diabetes, meaning their sugar is elevated in one of the 3 ways that you said on a blood test? And how do you decide whether you start medication? So many of us want to think that diet, exercise is going to make everything better, and we really do hope in a lot of ways it is. But what do you tell someone? How do you decide that someone needs to go on medication?
Once they're diagnosed with diabetes, the general approach is to start medication. And that's not to say that diet and exercise is not important. Diet and exercise is the most important part of diabetes management. The problem is, and I'm sure you've had this in your practice, is that that's the hardest thing for people to do. We're creatures of habit, and we continue many times to eat the way we've always eaten, and exercise or don't exercise in the amount that we have always have. Asking people to change those things becomes very, very difficult, and most people don't. But if you ask me what's the most essential part of diabetes management, it would be those 2 things: diet and exercise modification. 30 minutes a day of cardiovascular exercise, 5 or 6 days a week would be excellent, and a low-calorie, low-carbohydrate diet. So 1,600 to 1,800 calories a day with minimum amount of carbohydrate consumption, and diet should be consistent with basically a Mediterranean-type diet where there's lots of green vegetables and lean meats, turkey, chicken, fish, things like that. Even small amounts of beef are okay so long as they're not associated with large carbohydrate consumption. So that's the diet and exercise component. But because most people don't do diet and exercise, all the guidelines have now told us, initially they used to say, okay, give the patient 3 months, and if after 3 months they don't improve, start medication. Now what we generally do is we start medication at diagnosis and see how patients improve, because medication can always be removed if the patient no longer needs it. What tends to happen is we have this concept of therapeutic inertia, where a patient comes to us, sugars are high, and we counsel them. We say, do better next time, do better next time. And then 3 months go by, and they might miss an appointment, and then 6 months go by. And all that time, the patient's blood sugars have been high, and they have the chance to develop the complications of diabetes, which of course we don't want to do. So that underscores why early treatment, early, with medications, and whether those are oral or subcutaneous or insulin, early treatment results in the better long-term outcomes, and basically all of the clinical trials that we've seen over the years have kind of made that point to us.
It's funny, in the evolution of my career, what I've seen different than diabetic medication treatments is really that there's a category of medicines, and many of our medications don't lower your blood, don't make your sugar lower than they should be, low, abnormal or hypoglycemic.
Yes.
You know, and when I was in training, everything you gave someone, they could go very low and be very concerned about that the sugar would be low. I think some of the newer medications that you've been talking about over the last couple of generations of medications, you're able to give without people having their blood sugar go very, very low and become symptomatic from it.
Yes.
And that's part of this too.
Yeah, low blood sugars are one of the great dangers of diabetes, right? And it's something I always think about when I'm crossing a street or I'm driving my car. You know, who around here has low blood sugar because they took too much insulin, right? And that's why the monitoring devices are so important. The continuous glucose monitoring devices are critical for people on insulin because it will alert them and protect both them and the rest of us from their hypoglycemic event. But yes, when I teach my residents, I tell them there's only two diabetes drugs that cause hypoglycemia. One is insulin, and the second is the class of drugs, an older class of drugs called the sulfonylureas, and they work by binding to the pancreas and making the pancreas stimulate insulin release, but it does not do that in a glucose-dependent manner. What does that mean? That means that your sugar could be 30, and that medicine is still working, pushing your sugar lower and lower and lower. And we use the word miracle, and I think it's apropos in this situation. All the other classes of drugs that we have, the metformin, we can talk about these a little later, GLP-1 receptor agonists, SGLT2 inhibitors, TZDs, all of these drugs, the chance of hypoglycemia is 0 unless you use those drugs concomitantly with insulin or sulfonylurea.
That's why treating early is so important, and that's what people should feel comfortable with it. Let's go on to medication.
Yes.
So everyone's primary care physician, healthcare providers, many are really up to date with this. I've really seen how wonderful, especially under your tutelage at Rumsey, and really all over Staten Island, really very aware of what to do and really in management of this. I'm sure that they're not watching television commercials to figure out which medicine to use. And you've told me so often when patients will walk in asking you for one type of medicine they've seen on TV, they really are on that type of medicine but with a different brand name.
Yes.
So tell us, how do you start? Is there any, and again, everyone is different. Is there any idea of some kind of a model that we use, or what the more commonly used medications are initially? And again, we're going to even jump into the weight loss kind of medications because they're going to pop in. You know, where do they go in that model of what you're going to use?
Most people would agree that the way you start with diabetes management is with a drug called metformin. Metformin is great for a variety of reasons. It is efficacious. There's very low side effect profile. Maybe people complain of some flatulence, gastrointestinal upset, diarrhea, but most of the time it's very, very well tolerated. If you look at the studies, maybe 5 to 7% of people absolutely cannot tolerate metformin because of GI side effects. But it's efficacious, it's well tolerated, and there's no hypoglycemia, and everybody will be happy. It's cheap.
Right. It's generic, right?
It's cheap and generic. So that is considered the place that we start with diabetes. What you use as a number 2 is the area of intense controversy. And I'll try to address some of that with you today. If a patient has cardiovascular disease, there are 2 classes of drugs that we recommend: GLP-1 receptor agonists and SGLT2 inhibitors. And I guess we can talk about what those are in a second. If somebody's got a kidney disease, they recommend the SGLT2 inhibitors. And if somebody's got congestive heart failure, they would recommend SGLT2 inhibitors or the GLP-1 receptor agonists as the second line of therapy. And then, third and fourth line, there are a variety of other drugs that we use, but many times those people proceed to insulin therapy, either 1 shot a day or multiple shots a day. So I don't know if you want me to talk about what those classes of drugs are.
Absolutely.
And how they work.
And again, we're not in an academic center where we're doing this at grand rounds. We're allowed to talk about some of the brand name medicines.
Yes.
Because I think people are going to think about what they're taking and saying, look at my little bottle, I'm on this medicine, and have some idea whether this is one of the medicines you talk about instead of talking about with all the fancy letters that we talk about.
Yes, absolutely. So I mentioned the class GLP-1 receptor agonists, and what are these? These are the names that you see on TV. This is the name of Victoza, Ozempic, tirzepatide, which is Mounjaro. Those are the diabetes drugs. Trulicity is another one, right? And these drugs are really great entrants in the market because they have not only the ability to lower blood sugar and improve cardiovascular outcomes, which they do, but also they're, and very importantly, are very good for helping patients lose weight. And a lot of the drugs, like insulin, cause people to gain weight. So, you know, 2/3 of patients, 2/3 of people, especially in Staten Island, 2 out of 3 are either overweight or obese. People don't need help getting overweight or obese. So it'd be nice to be able to use a drug that concomitantly helps both the sugar and the heart and the weight. And that's what these drugs offer for us. And how do these drugs work that everybody sees on all the TV commercials? Well, they work at our pancreas and help us pump out insulin better. But they also bind to the appetite receptors in our brain and the hypothalamus. And in that hypothalamus, that medicine binds there, makes people full. And then they don't want to eat so much. But in some cases, that fullness can manifest actually as nausea. And some patients, you know, sometimes there's vomiting with these drugs. So it is something that you have to, I always tell my patients, expect it. And if they don't get it, they're happy, certainly. And if they get it, they know, okay, I'm okay. And so I don't need to call the doctor, but I always tell them that if it's severe, always give me a call and let me know how you're doing and how you're feeling. So that's...
How do you distinguish between the different medicines? And again, we have different blood pressure pills that do the same kind of things. I have different seizure medicines that help control seizures. So every specialty has, and it's good to have many medicines.
Yes.
Because they're all different molecules. If you're allergic to one, you could try another. Is there some rhyme or reason why people would use one first line or another one first line?
So if we're talking about that class of medicines that I just discussed, those GLP-1s, a lot of the time it's basically what your insurance covers. I mean, I hate to make it as inelegant as that, but insurance drives a lot of this. And so they usually have one or the other on the formulary, and the doctor will make that decision based on what your insurance will cover. But there are subtle differences, academically subtle differences in how they work, and also in the side effect profiles. Just as an example, we were talking about Mounjaro and Ozempic, both excellent medicines for lowering hemoglobin A1C or sugar. But Mounjaro happens to lower weight, help people lose more weight than Ozempic does, and we've seen this in some head-to-head trials. So all else equal, if we were saying, okay, if you have carte blanche to write whatever you want, if your patient needed to lose more weight, maybe Mounjaro will be the right drug to use for that patient. And Ozempic, on the other hand, has demonstrated cardiovascular benefit in prospective clinical trials. So that if a patient has established cardiovascular disease, maybe that's the one you select for that patient. So there are subtle differences, different differences in the FDA-approved labels, and I know this gets really technical, but a lot of it, as I say, is driven by insurance. And you have to also realize that, you know, as you mentioned, it's nice to have choices, nice to have a menu of things, because if a patient doesn't tolerate one, perhaps they can tolerate the other. And so
they're similar.
They're similar.
So nobody should feel that they're getting the wrong medicine with the 4 or 5 that you mentioned. They do very similar things and they're similar agents.
That's correct.
Just want to go into any other categories of medicine. You're talking about medicines that affect the kidney reabsorption of sugar.
I think that those are another class that's really important to talk about. And I know this gets, again, technical. They call them SGLT2 inhibitors. The brand names that you'll see this under are Invokana, Jardiance, Farxiga. Those are the 3 main ones that we see people taking, and these are medicines that work at the level of the kidney. Now you imagine the kidney's job is to filter things and then reabsorb things. And one of the things it does that with is sugar. So the idea, if you think about it, is if you're filtering it, it's coming out into the urine, and if you don't reabsorb it, it can come out in the urine. And so when you lose sugar in the urine, it doesn't get reabsorbed, so the blood sugar comes down. And also interesting, when you lose sugar in your urine, you lose calories in the urine. And when you lose calories in the urine, you lose weight. So this drug therefore works in the kidney, lowers blood sugar, lowers weight, again, and also, and most importantly, has demonstrated cardiovascular benefit. So it actually protects the heart from diabetes, but also protects the kidney from diabetes. And I remember when these drugs first came out, everybody said, "Oh my goodness, these drugs are working in the kidney. Is it bad for the kidney?" Now we know not only is it not bad for the kidney, but it actually protects the kidney, and it has a clinical indication to use for people with diabetes and chronic kidney disease, but also now it's approved for those individuals that don't have diabetes but have kidney problems. So it's pretty exciting developments with that drug.
So it's funny, we're going to talk about diabetes with minimal talk about the actual types of insulin.
Yes.
Because there are different kinds. Thank goodness they're available now at more reasonable costs. As I think in one of our last conversations, we saw there was issues with cost. Now it's gotten a little bit better, I think you've told me.
Yes.
So maybe just if you can because we only have a couple of minutes left,
yes,
just even a few seconds on insulin, and then I really want us to be able to talk about new therapies.
Yes.
What's coming up? Because some people do well with all those medicines that we said, and there's combinations, and we use sometimes this term rational polypharmacy.
Yes.
We use a little bit of this and a little bit of that to get the end result. We used to be very much into one drug and hopefully to get there. But now we're very comfortable using multiple agents to get the benefit of each one of those agents.
Yes.
So maybe just let's touch on insulin and touch on new therapies.
Yeah, and just so the audience is aware, another change to the Medicare program is going to be that the maximum out-of-pocket cost for the prescription drugs this year will be $2,000, which is really good news for our patients trying to afford their medicines, because that out-of-pocket for the individual patient used to be $8,000. So it's a dramatic improvement. So
Absolutely.
People that have had trouble in affording their diabetes medicines, but also other medicines, there will be significant changes this year that they should talk to their doctor and insurance policy about. Getting to insulin, there's a variety of different types of insulin, long-acting insulin, which lasts 24 hours, but also some patients advance their condition to where they need short-acting insulin for each of their meals. So they'll take it with breakfast, lunch, dinner, and even with snacks. Affordability has been a challenge over the years, but it has gotten better of late. So I'm happy to say that's getting better. There was one
we
other
have
topic.
30 seconds to talk about
yes.
new things.
New things. Well, what I would ask people to look at is the drugs that we're talking about, the ones that I mentioned, those GLP-1s, the Ozempics and all. That class of medicine there's great promise in that class of more therapies that are even more efficacious with weight loss and A1C reduction that are right on the forefront and coming very soon.
I want to say thank you. I want to thank everyone for tuning in. Diabetes can be a devastating disease. People are always concerned about losing limbs, vascular pathology with it, and it's become an eminently more treatable disorder if you go to your doctor, you get the blood work, you don't have to feel sick to get blood tests, and the new medications that are out have a lot of positives with weight loss. Also, they help treat the diabetes. So thank you so much, and take good care of yourself, and let's find out if you have diabetes.